Okay, let's kick off, colleagues. What have we got? We've got 11 or so in the meeting, and perhaps a couple more will join us. Hopefully, we'll see. So just first of all, just a warm welcome to this first of our professional learning series engagements for 2022. I'm very grateful for the support last year and in our pilot year of the professional learning series. And what I'd like to do is just say a word quickly about the structure of this year's series, and then looking for us to engage in this particular topic on your screen at the moment. So first of all, we're going to keep to the same format for the work of our good partners in the Centre of Health Sciences Education, the DFMPC and CHSE respectively, and together. And we thought that we'd keep to the same format of structuring these engagements. In that, we'll keep to the journal club equivalent for the first session. The second session being a Tech Tuesday, when we'll be looking at the technology applications in relation to the particular topic, or the particular theme, should I say. And then the third will be a learning workshop. So that would be around 3 themes at a time, interspersed every fourth session with looking at specific teaching and learning related competencies that would primarily, as we did last year, with a look to be trying to build a teaching portfolio, is where we came up with what we focused on last time, but that will then get a little bit more diverse in terms of our engagement, engagement this year. And Anaya, if I've pronounced your first name correctly, forgive me. So we are.
It's Ania.
Thank you.
Close.
Thank you. From Richard to yourself, my apologies. So we're looking at getting them sorted out, and I hope that we can be able to report back on that as in the near future, in terms of being able to secure those particular CPD related points. I think that allow me to then just look to Yanis. I wonder, we haven't discussed this before, but is it worth us speaking to the overall program, Yanis, or can we commit to sort of sending that out in the near future, potentially, so colleagues can structure their schedules and think about which ones to come to? What are your thoughts on that, if you would, Yanis?
So I don't have the program open now, but we can share it afterwards.
Okay.
Bear in mind, there might still be slight changes because people haven't confirmed yet.
Exactly.
But the next 3 sessions is on case-based learning, and how do you bring, so how to write cases, but also how to integrate case-based learning in your teaching and learning. And we're getting somebody from the business school, well, the head of the business school case study unit to speak to that. So that has been confirmed, but the rest of the series after that has not, we're still trying to finalize.
Exactly. So we actually moved things a little bit around and about for even these sessions. So because of the availability of colleagues and targeted presenters. But when we have it, then we'll send out, let's put it this way, to commit to sending out as soon in advance as we can. Good. So this particular theme is around for these 3 sessions is around making the most of training in the clinical spaces, or making the most of time towards training. Colleagues, we quite simply have a problem, if I may put it like that. And I'm deeply mindful of us having colleagues from the School of Therapeutic Sciences and the like. And so I don't want to be putting words, don't want to be speaking for you, but allow me to say that in other schools for that matter, But in the School of Clinical Medicine, students don't take advantage of their clinical time, their time in the clinical spaces. Time and time again, a student will finish up with the formal learning opportunities, all of which are potentially completed by, well, fairly early on, and will then be looking to get out and about, get out of the wards and get back on the transport, back to VITS, back to the accommodation, back in their car. Perhaps I'm being a little cynical in saying that in stereotyping all of the students in that way, and that would certainly be a valid criticism. But really, students are not taking as much opportunity as we as the School of Clinical Medicine would like to learn and to make use of creative ways that they can learn in the wards. And what I was hoping is that through these 3 sessions, the objective of the 3 sessions is to attempt to reflect on what's been written about a little bit, and I'm going to reference a particular text now. But secondly, of what creative ways in which students can use their time. But secondly, to come up with ideas of our own, particularly in the learning workshop, and potentially even today and next week as well, that you may have ideas that you can share around what students can do creatively with their time to learn. But also to look to a potential strategy, if I may put it that way, of how students can be involved, how we can motivate students. So what might that be? Can we pilot 1 or 2 initiatives, or pilot a way in which we just think a little bit out the box to try a particular activity with students for engagement in our own teaching in the clinical spaces, that just are out the box, and that we could come back here perhaps in the 3rd week, or we could just give it some thought and pilot it in a small way and come back in the 3rd week, and then be able to just reflect a little bit on what might work and what might not. One of the single biggest problems in the School of Clinical Medicine, if I may say, is that students, as our head of school frequently speaks to, is our students are focused on assessment. Not really interested in, again, I'm being cynical and forgive me for that, but have much more of an interest in just passing the block, passing the rotation, and not interested in getting completely in the training, and letting the training happen in itself, and then the assessment will take care of itself. And look, I mean, no student is necessarily going to just risk it all on that basis, but can we redress the balance? If we're going to identify it as a problem, we need to put measures in place to address it. And we need to pilot them, I humbly suggest, because otherwise, pilot ways, and they might work, they might not work, but there must be, can there be ways in which we can start to think out the box and start to, even in the smallest way, potentially just tweak the culture of our students. I make note in this introduction that really we must be, I'm deeply mindful of taking when I take a cynical approach in terms of stereotyping a student and being negative, well, actually, have we truly provided them, provided the support towards taking proactive and self-directed steps to maximize their learning in the wards, in the clinical spaces? And the answer is probably no. Well, it's definitely no. In my case, in my career as a clinical academic, as an academic clinician, I certainly haven't done as I should have in that regard. And so, I don't wish to place the blame on the students, certainly. Rather to look to ourselves, as we always must do first, and see are there ways in which we can improve. And this is what this is what I'd like to suggest as ways. Now, as our engagement for this particular theme. Next week, in terms of the Tech Tuesday, we're talking about learning in the clinical spaces, but are there online tools that perhaps not around learning competencies, I beg your pardon, clinical related competencies. But what are those tools that allow us to, that are the best people that have come across, and we'll look to recommend or suggest or put up a few for interrogation of tools around knowledge-based competency and around situating their learning in preparation, perhaps for the clinical setting. And are there some appropriate, some decent websites, some tools, some different online mechanisms, online tools, online spaces that can potentially be resources that can assist students to be able to do their learning in preparation for the clinical spaces. And then we'll come back in the third one, and perhaps next week we'll identify whether we can't just which is your thing that you'd like to try, your pilot that you'd like to just give a go with 2 or 3 students, 5 or 6 students, whatever it might be, that is just thinking a little bit out the box in the clinical space. And can we do that? Okay, so with those brief remarks, I wanted to just reference a particular resource. And that is this, if I may just share my screen. And that is 101 things to do with spare moments on the ward. Can I confirm that you can see my screen, Yanis? Or someone?
Yes, we can.
Okay. I'm actually rather going to potentially, yeah, no, let me stick with that for the moment. Okay, and I hope it's big enough, but let me rather see if I can move this to. I'd just like to reflect on some of. Okay, I think you can hear me. I'm back. Sorry, I lost connectivity there. Let me go back to my. Can you still see my slide? I think so. Okay, so allow me to just make a few qualifications around this particular publication. First of all, when I saw this publication, you know, I had huge expectations, and as one would have, I guess, in that we're trying to find ways in which students can make the best time of their time in the ward. And is this the golden ticket? Is this the answer to all our problems? It isn't, in a nutshell. The reason being, for a couple of reasons. One is it's not only about putting things in a book and then they work in practice, but it's also in a very different setting. And so not everything is applicable. For example, these 2 individuals, these 2 editors or authors, should I say, are based out. It's based they're out of the UK, and it's based and it speaks to the UK system. So what is that South Africa is not? First of all, it's quite well resourced, of course, compared to the South African setting, and I'll point out a couple of instances in which they're looking at one, for example, linking up with certain specializations that quite frankly don't exist, or certain mid-level workers. For example, as a medical student, you might link up with a phlebotomist or an ECG technician, that may not well be present and exist in certain clinical settings. The second thing, though, to note is that it is, which is interesting, is that it's put together largely around student input, undergraduate student input from the UK system. And what that means is that they've come up with nuggets of suggestions, with ways in which they can that have worked for them to engage in the clinical space, that have helped them look to their learning and try to make it a little bit more creative and think out the box. That's interesting, because just to place that seed of thought, are we able then in our third session, when we engage or in this somewhere in this theme, speak to, well, where is our student input in this, in perhaps towards a similar publication that may then just add to starting the culture of improvement, the culture of taking advantage of all the time we have in the ward. The other point before I proceed is that there are, in terms of the 101 things to do, there is a real focus on allowing students themselves, as I said, to suggest and look to put specific tools, specific tasks or specific things to do. But in some instances, it might be quite resource heavy. Again, mindful of the better equipped and well-resourced settings that the UK is, as opposed to the South African context. But be that as it may, I humbly suggest that it might be a start of just something that we can reflect on and build on. And many of these things we might be doing already. Many of these may be replicable, others not. But let's have a look at some of what they suggest. So it's, as I say, it's centered around particular quotes and from students. And the first section is on the teaching and learning, but teaching, testing, and learning. In the foreword of this book, they speak about, which I think will resonate with a lot of us. The foreword is introduced with that this is an extraordinary book built around quotations from medical students and turned into a beautifully woven catalogue of learning opportunities around the ward. Walking to the wards to teach medical students, I often ask, what did you learn yesterday? The answer is often I went home as the teaching was cancelled and there was nothing to do. A source of great sadness to me, and dare I say it, almost equivalent to a child saying I'm bored, with a hidden implication of entertain me. There's just so much going on in both the hospital and primary care settings that I'm often left speechless. But was I too harsh in my judgment? If students did not know what the learning opportunities were, or indeed how to find them, then their reply to me was hardly surprising. So I think that I'd suggest captures a lot of what many colleagues on the call now might be able to reflect as to the relevance for them as a clinical educator, if I may put it that way. So in the teaching and learning section of this is the first section is largely focused on building knowledge-based competency. So really a lot of this is not particularly useful in terms of, I beg your pardon, it's very useful, but nothing particularly new around, for example, the use of memory aids and mnemonics as a way in which to remember things. It's interesting that because it's so student-based and around the students' inputs, there's a certain crassness, if I may say, to some of the memory aids and mnemonics that appeal to our younger colleagues around the mnemonics that they use. Were we there once? Most certainly, colleagues. So there are a number of mnemonics that they speak to. Not least, for example, the carpal bones mnemonic, as you'll no doubt remember. And so moving quite quickly through this, because there is because these are some of the things, and we'll look to share this with you. Just on that, Giannis, we've engaged with Devon about this particular, about accessing this particular particular resource and wanting to share it, and we were a little concerned about using this one because we hadn't got our permissions, but we're looking to do that, and I think we will be able to, it seems. Am I correct?
Yes, that's correct. He said he'll ask International Library to get access that we can also share the PDF with people.
Thank you, Giannis. I found this one quite interesting, and that if students spend a bit of time in the ward, or even in their own time, again, thinking about looking into the origin of medical terms and diseases, how does that assist their understanding and prompt their thinking about what different terms might mean, their understanding from a medical perspective? I wasn't aware that diabetes means a siphon in Greek, and explained that patients with it had polyuria and passed water like a siphon. And so then knowing the etymology may help to recall this knowledge later on. So Duncan Davidson, as a medical student, came up with that little suggestion. The book is structured around taking it a step further. So every single time there's this is number 2 of 101, there's a tip or a suggestion. When they then include taking it a step further. And for example, Paget, who is Paget, who is Wilson, of Wilson's diseases. And it just makes it a little bit more interesting. These are not new to us, colleagues, in many instances, and don't speak to exactly how to perhaps make use of the time in the clinical space. Applies to the at home and any particular learning environment. But nevertheless, interesting to have a look at them. I don't know how many of you created your crosswords for medical terms as a start. It's low level in terms of really first year, but I remember doing that actually in my first year of medicine. So moving to and studying using flashcards, for example, is a commonly understood tool or technique for as a memory aid mnemonic. The second section is on clinical communication, and I'm also going to pass through quite quickly on this, in that this does speak to just some tips around communication skills and what to do, and that there may be some ways in which one can prepare appropriately for taking a history. One can how you might take a history appropriately, clerking patients. This is part and parcel of our curriculum, it must be said. And in family medicine, for example, we would speak to the importance of the Calgary-Cambridge model, for example, the Stewart's model of patient-centeredness. And this book speaks to both of those as frameworks, as efficient frameworks by which to take a history and a physical examination. Timed histories to prepare for the OSCE is something that is suggested as another particular skill. So the communication around, I beg your pardon, the communication section has a number of ways in which a student can look at particular ways, particular frameworks of taking histories, communication, and in particular. On the physical examination side, and I just want to speak directly to this, is that there's quite a significant section on just peer practice for physical examination. Now, this is worth, I think, some thought, colleagues, as to in which programs we take advantage of self-directed peer review and peer practice as a means for students to engage, to enhance their learning, but with some peer review and engagement, which then allows, if certainly if within a small group, one could argue that there's a fairly decent level of critique within that group of what they are doing, what the individual patient is doing around peer practice. And so can they look to a willing colleague, of course, in a suitable environment, and maybe a second colleague as well, that allows them to be able to role play and practice appropriately with the spare time that they might have in the wards. Are we doing this enough? Do the students do it enough? If they don't, why not? Is there ways in which we can motivate them to do so more? I leave that for our discussion. In our Train the Clinical Trainer course that we run within the Department of Family Medicine and Primary Care for the registrars, and indeed the clinical educators, that we do a lot of this role play where three come together, and we have the assessor is the focus there, as opposed to the trainee, which we're talking about in this instance. So is it something that we can make use of a little bit more? Examining patients in systemic systems examinations. So of course, just examining another patient and seeing as many examining and clerking patients as you can. I neglected to mention that this book does up front speak to the ethics of informed consent. Forgive me, that was a real oversight. And some of the important principles of what to do and what not to do. Knowing when you can start, and knowing not to start in the first place. When to stop, beg your pardon, and when not to start, if there's any reason for there not being appropriate consent. And when we share that, you can have a particular look at that section. But okay, we all know that students can make the use of should be clerking patients, should be seeing patients. I'd be grateful if our colleagues from therapeutic sciences could also reflect on some of the differences there in your settings with your patients. I'm mindful that I'm being fairly medically focused in terms of the MBCHB GEMP program and clinical associates program here, colleagues. But this was, I found quite interesting. In terms of doing holistic assessments, is there something that can be done? If you're standing in the ward, if a student is in the ward and they take the task of doing the same thing across 6 or 7 patients, so not clerking individual patients, but perhaps looking to an individual, looking at a patient and examining a patient potentially through a particular lens or with a particular outcome in mind. And is that something that we could practice more, that we could advocate for students to do a little bit more? They speak here of fluid status being one, something that one can do across a number of patients, in terms of taking 5 patients, they suggest, in the surgical ward, assessing the fluid status across all of them, looking at the vitals, checking the fluid balance over the last 3 days, fluids in, fluids out. It immediately asks the question of a student on their own as to what the appropriate expected fluid intake is, what the appropriate fluid output is in the context of the normal patient versus the patient with CKD, for example. And then how is it that the blood results, etc., and everything impacts, or one can look at the investigations and the drug chart and the like that speak to that particular lens, the fluid balance. Clinically, again, as well, can one get a sense of that? Again, through that single lens, short, quickly, efficiently, and then look to another patient in the ward. And then the other one that they use is looking at it from just a slightly different perspective. Now, one needs to be careful around this, and that this speaks to the interprofessional competencies, not careful per se, but respectful of, where does the curriculum, where do these particular particular skills sit. So here, an assessment of a patient's speech, language, and swallowing. Well, you know, for the specific colleagues on the call, would we allow a medical student? In what way can we have a medical student thinking slightly out the box, of looking through the eyes of a different professional? Again, ethics allowed and not going outside of one's scope, etc., etc. But can one read about that particular issue for a group of patients in the ward, etc.? Perhaps a better one is, you know, is a patient well or ill, and can you assess on the basis, again, maybe at GEMP 1 level as opposed to GEMP 4, but often knowing quite simply whether a patient is well or ill, and what on observation, if nothing else. And is a way in which, and it is useful for at registrar level, to be honest. And therefore, you know, does one not get into the detail, but look to stand and have a bird's eye view? Spot diagnosis. Can you make instant spot diagnoses? Again, they specifically speak to this in the OPD context of two students sitting together and observing the patients sitting on the benches, or in the wards for that matter, because there's a feedback that you can use for with looking at the clerking notes or speaking to the patient. And can you perhaps not in the bed, everyone's in the bed, so it's the same, but what can you observe about a patient that may tell you about their condition, put it that way? And I suggested that could be quite fun between two students. They speak specifically to the consent issue here, is that, look, you don't want to be staring at patients and they feel uncomfortable and you're whispering and talking to each other around it. But again, just looking at thinking a little bit creatively. They give some tips around how perhaps to do that. Spot diagnosis, and then exploring around the patient. You know, we speak to the NMFC students who have limited time, the Nelson Mandela Fidel Castro students. We speak to them about the importance. I speak to the framework of really initiate, situate, and elaborate is how we frame it. In that you must use the patient as the hook. You must initiate your learning around the patient, not the guideline or the textbook, but around the patient who presents with X. Then you situate that presenting sign and symptom in terms of the guidelines, and then you can elaborate further if you want to speak to Grants or Harrison's or whichever we might be looking at in terms of more complex textbooks at an undergraduate level. Now, this also found was quite interesting, and I, you know, we always speak to the correct sequence of events and taking a history, understanding the presenting complaint, history of the presenting complaint, etc., and going through, coming up with a differential diagnosis at the end of history, looking for your clinical examination to confirm back. 90% of the diagnosis is in the history, so they say, etc. Then you come back to the clinical examination to confirm that thinking. Then you look to the investigations. Just once in a while, could we advocate potentially for students to pick up a random X-ray and then come up with possible differentials from that? Is it risky for not having a you know, if we're going against the grain in terms of the structure, potentially so. But is there a way in which one can observe from a distance of the chest X-ray, or even look to see what again, observing the different patients from a distance in the ward and see what equipment is in place, and can one come up with a possible differential from that perspective? Not too different to the previous one of making a spot diagnosis. Then the next section is on practical procedures, and let me go quite quickly on this, because if if there's some, but there are a couple of ones that I wanted to highlight, and these are not rocket science, but are we doing it to the extent that we, or advocating to the extent that we can? So, for example, how many of us request of a group of students or require a group of students to go through the emergency trolley, to approach the scrub sister in theatre for an explanation of what all the different what the different equipment is, and just the opportunity to go through this to know the equipment and have a particular project around that at the beginning of an early clinical assessment, a clinical rotation. I mean, early in their training. But they even speak about a little project to understand how the beds work. In that, how do they get put up and down? How do they, which of the buttons they're pressing? Again, the fancy beds in the UK hospitals are perhaps another story. So that maybe there's some complicated learning outcomes that students can focus on, but and it might not be the case in South Africa so much. But nevertheless, is there an equipment day that we can include in our curriculum, for example, whereby, in our academic program, whereby the students are required to go through the different equipment? I suggest that perhaps our therapeutic colleagues, sciences colleagues, are maybe a little bit more practical in this regard and better at our getting your students, colleagues, to get involved in such activities. I'm not sure that in our Dr. Way standing at the end of the bed and pontificating about this the patient's diagnosis, do we think along in the same way? Again, peer practice of the practical skills that can be done, and critically some ground rules for practicing, for doing peer practice, not only the history taking, but peer practice in the clinical context, and how do we go about that is in a way that's appropriate, not only in the context of patients, but also with do we want to have a framework by which we speak to the ethics of peer practice around practical skills. We still have to be deeply cognizant of that. And then hidden teachers, hidden opportunities for practical skills in engaging with colleagues. I was interested in their reflection, as we all do, is you have to have a fairly thick skin in terms of asking others to teach you. And are we teaching? Are we coaching? Are we teaching our students to do this appropriately? Do we just expect them to get on with it in the wards and approach different people? Are they not doing it because they simply don't know how? And many will say no, and clinician might be particularly grumpy and not be comfortable in teaching at that particular point. How do we motivate the clinician potentially, or through the student motivate the clinician to get involved? And then just prescribing is a whole section, and I noted a couple of colleagues from pharmacy on the call this afternoon. One or two neat things that I thought a student could do is from this particular text. One was the errors in prescribing. Can you spot medication errors? See how many medication errors you and your peers can find. Have a prize for the one that you can spot the most. I'm sure if we went through the clinical set wards in which I'm working at the moment, with some embarrassment, I would suggest that there are many errors on the charts. But not only many errors, but potential interactions between medications. So errors in prescription, in completion of the drug chart, but errors in for the interactions between medication, for the cognizant of the comorbidities the patient presents with, for the when they should have been stopped and weren't, for potential unnecessary polypharmacy, etc. And can we just as one might look at an X-ray or look at a patient times 5, can one just look at doing spotting medication errors? There's also in the same as book is in the another suggestion is that you don't only check for the errors, but, and there's the taking a step further, but where is it now? I think it's around just rewriting it, or taking all of the medications from a particular drug chart, particularly medication chart, I beg your pardon, and looking at understanding each of them with respect to this particular patient. You can do a file audit of 6 patients and use that as a learning exercise as to who is on what for what reason, and matching this patient with that for being on the same medication. They're suggesting that as a contributing to service, of course, which much of this book is about, is how can you help? How can you just do tasks that help? And writing out the new, as they say, reboarding of the medication into a new chart. That's got to be done by somebody. And can we advocate for the students to look to take that opportunity to write things out again? Some of this happens in our clinical spaces. What's the hidden teachers in pharmacology? Speaking to the appropriate professionals, but the hidden teachers is also the patient themselves. Talking to patients around their use of warfarin as an expert patient. It can be quite clear that many of those on warfarin chronically for atrial fibrillation or a particular diagnosis chronically know as much as certainly the undergraduate medical student and intern and ComServe and many more. So can you engage in that? And then this is an interesting section as well, and really an absolutely vital one. But how is it that colleagues, in terms of the being curious and working with others interprofessionally, if the pharmacist happens to be in the ward, or there's a clinical pharmacology component to the function of the ward, how many times do we have an undergraduate student taking advantage of that, and at the same time building the respect that for a pharmacist that they should have, or working with a nurse, and again engaging with a nurse around their particular role and what they're doing, and therefore picking up on for example insulin regimens and looking to the medication chart, but working through it with the nursing staff. Am I being idealistic? Am I being naive and that can't happen? Well, maybe it does need to, does it not? And how can we move towards that? Curiosity, confidence, courage, and constancy. And the greatest of these is confidence, said Walt Disney in this particular chapter. The doctor's best friend is the nurse. Who are the other players? And I've mentioned a couple. I was reflecting on, the biopsychosocial approach that we're teaching our students in GEMP 1, GEMP 2, and then through to IPC, particularly in family medicine. The international classification of function that our physiotherapists and occupational therapists use so well and so adequately to understand patients from a holistic perspective. If we ask students to consider the biopsychosocial approach for patients in OPD in the wards, but they were to do both, is that not just a little bit richer? Is that a little bit more interesting that they should use the biopsychosocial approach, but also understand the participation restriction, for example, in the international classification of function? Does it not just make it a little bit more interesting? Is it too much to put both in the mix? I leave that to you. The data interpretation, just finishing up, and that is the using real patient data. And this is something of initiate, situate, elaborate, but knowing what is normal. I suggest we don't do that as much. And is there a particular project or initiative that we can introduce in a rotation around just understanding what is normal, rather than learning about hypertension or learning about a headache that then is associated with hypertension, etc. So if you do look at the notes and a student can look to engage in the notes and just trying to follow appropriately. It doesn't take a lot, but I wonder how many students are just going through the notes and separately to clerking the patient, and understanding that and presenting the patients. The clinical governance section here is where they speak to audit as a possible tool that a student could get involved in, and yes, many of us have orders as a particular project, but really a file audit is what they're referring to here, in that a student can also, students are so critical, appropriately in many instances of faculty, of clinicians, in many instances critiquing a set of notes, and challenging oneself as an undergraduate to do so, perhaps is something that might we can think through. And then let me close now, and you can go through this as well when they're fun and flippant suggestions, which are a couple of others. The patient notes, patient ECGs, and that they use here, practice of doing the particular skills. This is where the resources came in a little bit, where we can't easily just practice and use the chest stickers, for example, and to do an ECG just willy-nilly, but are we able to think a little bit about out the box in terms of ways in which students can practice? And then in teaching, motivating people to teach you. Well, this just speaks to ways in which we can try to motivate the students and motivate the teachers as well. And this section specifically speaks to the keen teacher and the not so keen, and that we have to really we need to train students to be a little bit more resilient, a little bit more just try again. If you don't succeed, try again, in terms of looking to link in. But of course, as we all know, the key is to be helpful up front, and then people are happy to teach. Okay, and then the section finishes off with the over to you, which is really the last task of the book, and that is and this is really just a call that perhaps I put to you as a task, if I may, to finish up this particular fairly unstructured, for which you'll forgive me, presentation. But are we able to think share some ideas on how to make better use of the clinical environment as a learning environment? This is put to the students, but also for us as a collective. And then in addition, can we spot some ideas for yourself? Try them out from this book. See which ones work, which don't. Are they all fairly lame? Are they not? Can we try some things? Can we just think a little bit out the box, in which ways we can do it? Thank you. Colleagues, just in the last few minutes, if I may. Yanis, is that your hand, sir? Forgive me. Didn't see it.
Yes, Prof, I just wanted to make comments, but I'll wait till you or just
Yes,
idea that I thought of, but I'll wait till you close.
Yeah, no, I'm done. I just a couple of comments would be grateful, and then we can look to prepare for our engagement next week and the following.
Thank you. So last night I was working on the work integrated learning component, and I share this resource as well, which I found valuable for around work integrated learning. And one of my thoughts was, although it's not exactly clinical, is that when we place the students in the the in the work integrated learning environment, how are we going to keep them busy and make sure that they see things and so forth? And that made me think about what to do in the clinical space, and this with this book focuses nothing on health systems, but what if we give them so with the portfolio that we provide them, maybe give them a chance for additional marks to research challenges in the health system and so forth, or identify challenges that they see on the wards and so forth, and describe that and so forth, and they can submit that as part of their portfolio. So yes. It's only so if we actually have a section where we say things to do in your spare time, in our study guides and so forth, and maybe highlight a few things that they could look at. Yeah.
No, that's exactly. I mean, one wants to be fairly broad and looking at the non-clinical related learning outcomes and the clinical related outcomes for a clinical student. And then in the case of health system sciences, for example, we would build those cross-cutting themes of the non-clinical related learning outcomes appropriately. I note that where we have a certain problem, colleagues, is not that I've already articulated, but for our clinical students as well, this balance between online versus clinical is becoming a little bit uncontrolled, and we're leaning towards online because it's convenient, because it's but what we're trying to redress or get back to appropriately that it's in the clinical space, working with patients, that our students need to be learning. And can they do that in a way that is, can we come up with more innovative ways around which to build that, to get value add from that time? Absolutely. I know, thank you, Shira, for sharing. Is that yes, and you share the article below around curiosity, so colleagues, please do have a look at that. And then this particular, what is this the practical guide that you, yes, I think, Yanis, that you're speaking to in terms of the work integrated learning context, more particularly outside of the clinical, not related to the clinical related learning outcomes.
Yeah, and there's some really really great reflection models and so forth in that, and they also give examples on how to evaluate programs and so forth. But yeah, just one more thing, with regards to this 101 ideas on the clinical space, one of the things, can I just quickly share my screen, that we
just here as well, while you're doing that, is there any other, just to hear from comments or colleagues from the School of Therapeutic Sciences as well, and some of the colleagues on the group, or from clinical associates or others, if there's anything that you find useful, then we can reflect on that and also engage next week on and the following on some of those techniques. Back to you, Yanis.
Just on that, should we not make, so I've started creating a list. I've only started recently doing it, that we're going to populate around the types of activities for self-directed learning and reflection. So I, for example, took some of the reflection activities out of that guide in here, so the daily backdrop and so forth. But as a collective, should we not maybe come up with a document like this to describe an activity and say what it is and how it could be used in the clinical space?
Very good. I mean, if we can have a template that we could populate and with one or two tried or tested or suggestions that we can then, we kind of want a quality improvement process here that we could potentially be able to just start a seed of thought and a seed of to change the culture slightly. So agreed. Absolutely. Okay. Let's look at doing that in our learning workshop. We can probably appropriately populate. I just want to recognize some of the comments in the chat around this, and that a number of individuals have spoken about the issue of curiosity and how do we generate curiosity in our students. If we had the answer to that and we were successful, would we have to do anything, colleagues? I'm not sure. That is something that we might want them to play with some of the activities. Yes, games, standardized assessments without wasting expensive ingredients or forms, and to learn one new activity for their repertoire, thinking of how it can be used for assessment. Or speak to a patient with a diagnosis with which they do not have experience, similar to the example of a quick 10-minute interview with a patient. Some of our fourth years last year used spare moments to do a work study analysis of the protected workshop at one of their placements. So you think there are a couple of ideas coming through around how to make use of the time. Shadowing a clinician, thank you, Bhavna. That is to determine the condition assessments and specific treatment techniques. Does speak to the importance of potentially having a far better clinician to student ratio, am I correct? And spreading our students more broadly, so maybe they're just one or two in a clinical setting and then they can get more stuck in, because otherwise it's challenging. Thank you, Avi. We're great to see so many tools for learning. Often students are saying, I didn't know what to do off the ward round. But are we helping them, Avi? I ask you, are we, some genuinely lack the creativity and initiative, for sure. These tools show that learning can be fun. I agree. Are we doing what we can to help students be curious, take the initiative, be proactive? Okay. Thank you. I'm going to. It's 5 o'clock now. I'm going to then leave it at that. If we may, can I please ask you to, so let's engage next week again, if we may, please, and bring some ideas, some thinking to the space. We're going to be looking at the online setting, if we can, but if that's going to be, I think, the focus of what we're looking at in terms of just trying to create curiosity, engage maybe in games in that space. Is there some ways in which we can generate the curiosity in preparation for their engagement in the wards? And then we'll set up some time or some particular small projects, if we may, for the following week, where we can just try one or two things that are easy to do, that don't take any time, but we can just reflect on it and come back on and workshop it a little bit in the third week. Critical that we just try to do something around this so that we can be better prepared. The students can be better off in the wards. Colleagues, thank you very much for your attendance, and I look forward to seeing you next week. Thank you, everyone.